Welcome to this latest Davies Veterinary Specialist Out of Hours podcast. My name's Ian Battersby. I'm Head of Internal Medicine at Davies. As you can see, the setup's a little bit different to our normal routine. We often film these discussions in the pub or in another location, but it's during the COVID lockdown, so we're doing them remotely at home. Firstly, before we continue, obviously, hope everybody's staying safe, and a massive thank you to all those key workers in the NHS, but also the support services who are keeping us all going. So we do Davies Out of Hours podcasts from time to time. They've covered a variety of topics, and they are available on YouTube with the visuals, but we do provide them in podcast form only with the audio. And if you're interested in getting some of those, please contact our marketing department. So far, we've covered a variety of topics, talking about pain assessment, physiotherapy, cardiac arrhythmia ablation, and there was also a couple where myself and one of the surgeons discussed the thought processes when you're removing an intestinal foreign body. So we're now going to move on to a slightly different theme, and I'm a medic, so this is an area that I'm a little bit more comfortable with than some of the surgical topics. We're going to move on to a stream looking at infectious diseases, and we're going to move through different topics. And today we're going to talk about Leishmania, and I'm joined by my fellow medic, Patricia. Hello, Patricia.
Hello. Good morning.
Good morning. So Patricia is a member of the medicine team, and we've worked together, so we keep that. So we just say a while rather than.
It's been a long time.
A long time, but we won't put numbers on it because they might. It was before I had grey hair. It's probably.
Yeah, I think I already had grey hair, but.
No, I don't say that. But so.
Just covering it now.
So what we'll do is we're going to just have a bit of a chat about some of the discussion points around Leishmania. Mm-hmm. And I suppose before we get into the kind of nitty-gritty of treatment decisions and things like that, it's probably just sensible to review some of the basics. So first of all, if you could just overline, there's the Leishmania species, and I guess primarily we're interested in dogs. Which Leishmania species affect dogs?
So Leishmania infantum is the most common one in Europe. So most of the cases in Europe are caused by that particular species. But there are other species of Leishmania that are seen in Europe, particularly in Turkey. So you get Leishmania tropica and Leishmania major. And then in South America, for example, you get other species like Leishmania brasilensis, for example, in Brazil, or amazonensis. So there are different species of Leishmania in different areas of the world. But in Europe, we are mostly concerned with Leishmania infantum.
Okay. And does any of those species have a, do they? I mean, because I know that Leishmania is we know Leishmania is a zoonosis. So do any of them affect different species more, or as in humans or dogs or cats? Or?
Yes, there are different kind of predilection for different species. So certainly Leishmania infantum affects people, and in Spain there are kind of areas where it's a particular problem in people, including Madrid, for example, where there are lots of people do become infected and sick with Leishmania. So it's a big health problem in some of these endemic areas. And the same can be said in South America. So Leishmania brasilensis, for example, is a big problem.
Okay.
And particularly in poor areas, it can become a massive problem just because of exposure to the sandflies. So it is a big health problem.
Okay. Yeah. And what about other species? So we obviously most of us talk mainly about dogs, and those are the cases we see. We see. What about cats? Are there, how do cats get infected?
They do get infected. So we know that they get infected. The question is, how often do they develop clinical disease? And that's a lot less common than it is in dogs, but there are cases of Leishmania in cats, and certainly they've done seroprevalence studies in different countries in Europe, and in some countries, in some studies, there have been very high seroprevalences in cats, up to 60%. That's not the average by any means. Normally it gets quoted between 0 to 3% of cats in endemic areas can be infected, but it depends on the areas, on the lifestyle of the cats and so on.
Okay.
And certainly in areas where there are stray cats, it might even be more common. So the issue is not so much about clinical disease in cats, that's quite rare, but whether they can be reservoirs for the infection. Okay. And we think that they can, yes.
So it's more of they seroconvert because they're exposed, they become infected, but they don't necessarily go on to develop clinical disease. That's but potentially they may be acting as a reservoir for transmission. And I guess
exactly. And they can develop clinical disease. It's just not as common as it is with those.
Yeah. I suppose that moves us nicely on to transmission, because understanding how we manage these conditions, we've got to always understand how they're transmitted. So if you want to just overview a little bit about that.
So the transmission is mainly by vector, which is the sandfly. So that's the main mode of transmission in endemic areas where they have the sandfly. So in theory, it requires exposure to sandflies. But there are other modes of transmission which are more interesting or more relevant maybe in non-endemic places like the UK, where we do not have the sandfly. Because obviously, we often get asked what is the risk of a dog with Leishmania entering the UK, and what are the chances of non-travel dogs becoming infected. And there are other modes of transmission that have been confirmed. So, for example, vertical transmission. So a bitch can pass it on to the puppies. Sexual transmission has also been proven.
Okay.
And then blood transfusions.
Okay.
So donors obviously have to be screened for Leishmania. Well, I'm not saying necessarily in the UK non-travel dogs, but certainly in endemic areas, you would screen for Leishmania in a blood donor.
Okay.
With regards to other non-proven modes of transmission, so there are some suspicion that maybe fleas and ticks very, very rarely would be able to transmit it, but that's not proven.
Okay.
And also potentially dog fights, so bites. And again, that's not proven, but it's suspected.
It's suspected. Okay.
And again, in endemic areas, these modes of transmission are not, that people are not very interested in them, because the sandflies are such a big problem that it's a minute percentage of cases that would be transmitted these ways. I think it's more interesting for us where we don't have the vector.
Yeah. So I guess from a UK, I mean, this is a UK based podcast, so I guess we're biasing our advice towards that. We may have dogs that come to see us that have been travelling into at-risk areas. We may have animals that have been rescued from those at-risk areas and shelters, and sometimes those patients, despite adequate communication with those centres, they may not have had the screening that for these kind of diseases. So that's always important to assume. And then I suppose we've got our our uncommon situation where we may have a dog that's been in close contact with a Leishmania dog, and there are case reports of in contact dogs. So moving on to presentation, I suppose I've seen different ways where there's been tables with different gradings of severity of disease. Then you hear like visceral Leishmania, cutaneous Leishmania. If you want to just overview the presentation that we may see.
So the main, by far the most common clinical presentation is dermatological signs. So that's the most common clinical signs that we will encounter. So about 80% of dogs with clinical leishmaniasis will have skin lesions. And then we'll have other, systemic signs. So it could be depression, weight loss is a big thing. They're usually dogs that lose a lot of condition, because remember, it's a chronic disease. So an animal that becomes acutely ill, that's not a typical presentation of Leishmania. So you would be needing to be looking for another disease. So there are animals that have lost condition over a long period of time. But it's not. It is possible for dogs to develop clinical disease without skin lesions. So the fact that they don't have skin lesions does not mean that they don't have Leishmania. And obviously, chronic renal disease is a big complication of Leishmania.
Yeah, and I suppose that's quite an important point that you highlighted there. It's not an acute disease. It's if anything, if I remember, there's case reports where patients have moved from an at-risk country and then exhibited clinical signs, years later. Have you read those as well, or?
Yes. I mean, it's not uncommon, and quite often when we see cases, there are dogs that have been in the UK. They can have been in the UK for months or even years. So it's not. The fact that they haven't travelled for a long time does not mean that they don't have Leishmania.
So I guess as medics, we always like to make sure we ask about travel history. I suppose that's a bit of an artificial, that's a different scenario to in first opinion practice, but certainly if you're presented with a patient that's showing skin signs or unexpected renal disease, it's always good to get that, longer history than over the last few months. So probably moving on now to testing, because this is, I mean, as we know, there's no test is perfect, and when you use a test, you have to use it in the best scenario to get the most reliable results. So I think this is an important area, particularly with Leishmania, that we go through. So if you just want to overview the options for testing in these cases.
Yeah, so there are three main, like with all infectious diseases, to be honest, there are three main ways of identifying, I suppose, disease, I should say, rather than confirming disease. The best way really to determine that the animal is infected is being able to find the parasite itself. So cytology is a very useful test. So if you have a skin lesion, or you've got an animal with ocular signs, whether it's uveitis or conjunctivitis or lymphadenopathy, so sampling those organs and finding the amastigotes within the cells, that would confirm infection.
And I guess there's bone marrow as well, isn't there?
Bone marrow as well, particularly where you've got hematological changes. So, for example, thrombocytopenia, that might be useful, but obviously it's more invasive. Whereas if you have a skin lesion, doing a skin scrape or an FNA is pretty straightforward. And it might be possible to even diagnose it in the clinic. And certainly in endemic areas where vets are really used to seeing this parasite, they can identify it very easily. Yeah.
And I've read about, I mean, I've never done it, but there's different ways. I mean, I know in endemic areas, they'll do bone marrows from the rib, won't they, rather than in the more traditional areas that we do. So yeah, I mean, proving the actual presence of the organism, the protozoa, is I guess the gold standard. But then we've got other layers of testing. Could you go through those?
Yes. So moving a little bit from actually identifying the organism itself, you could talk about PCR, which also identifies the organism itself. But obviously, the sensitivity of a PCR is higher than that of cytology. The reason being is that you're just a small number of organisms, you're multiplying them by using the PCR technique. So you're more likely to detect it, so it increases the sensitivity. But again, it depends very much on which tissue you choose to do your PCR on. So for example, if you do PCR on blood, the sensitivity is lower than if you do PCR, for example, on a sample that you've taken from the skin, or a lymph node aspirate, or a splenic aspirate, or a conjunctival, or a bone marrow, or a conjunctival scrape. So you always try to run the tests on the tissue that you think is more likely to be affected. So that's important. And obviously, one thing that particularly more relevant probably to PCR, because you're detecting minute numbers of parasites with PCR. Just bear in mind that the fact that the test is very sensitive reduces the specificity a little bit, in the sense that having a positive result means that the animal is infected, but it doesn't necessarily mean that that's the cause of the disease that animal has. And especially in areas that are endemic, where dogs are being constantly bitten by the sandflies, so many of them will be PCR positive. And it's important to realize that. So you always have to read the result with the clinical picture in mind, and does that clinical picture fit with Leishmania before you try to read your PCR result. And also we've got quantitative PCRs, which give you an idea of the load of the organism. So the higher the load, the more likely they are to be not just infected, but also have active infection, so clinical disease.
So I suppose that's a good point just in general medicine anyway. It's like the larger the screening-based test you have, the more likely you are to get positives, and that positive may be useful. So, for example, if this case turns out to be a Leishmania carrier, that's going to influence some of your decision making, particularly if you've got to immunosuppress them. But at the same time, a positive doesn't mean it's causing the disease. It may be that there's something else going on, which is a general principle for all medicine, but particularly important in this case. For sure. So then we've got serology left, I think, haven't we? So.
Yeah. And serology is really important, and is used a lot as a screening test. It is probably the #1 screening test used in Europe. Probably, I mean, each case is different, but it would probably be your starting test in most cases. I'm not saying necessarily in all cases, but in most cases. Now, what serology tells you is exposure. So because this is a chronic disease, if an animal is seronegative, it is very unlikely to be infected or have active, I should say, I'm going to correct myself, it's very unlikely to have active infection and clinical disease. Right. It is possible that it is infected, but very unlikely to be sick from the infection. Right. So infected animals that are treated can become seronegative, right, or develop a very low titer. Yeah. And that's why we use serology to follow them up, because as the infection becomes active, so the organism starts multiplying, and therefore more likely to be developing clinical disease, then the titer starts going up. Okay. Yeah. So normally, active infection and clinical disease is associated with a high titer. Okay. So in general, we do serology as a screening test. The higher the titer, the more likely that animal has got an active infection and clinical disease, or is in the verge of developing clinical disease. Okay, all right. Cool. But the three tests will complement each other. So there isn't one test necessarily that's better than another. It's just the three of them give you different information. If I don't know if I've made myself clear.
No, absolutely. And I was just thinking, with respect to serology, because of the nature of the disease, it's not an acute disease. If a patient, I was going to ask about how long it takes before it seroconverts, and could you get a false negative? But actually, that doesn't really come into play in this, really, because in theory, I mean, they could still be a carrier and not seroconverted, but by the time they're starting to develop disease, they should have seroconverted.
Yes, and that's it, that if they have got clinical disease, because we sometimes, with other diseases, like, for example, leptospirosis, which we will talk about in another podcast, but with leptospirosis, we know that we see lots of acute cases that are sick before they seroconvert. With Leishmania, if they're sick from Leishmania, they should have a positive titer. There are a few exceptions to that. And of course, if you talk, for example, I do a lot of CPD in Spain, and I talk to some of our colleagues in Spain, which see hundreds of cases of Leishmania every year, and they tell you about weird cases. And it's interesting to talk to them, because they will tell you about dogs with Leishmania that are seronegative. Nice. But it is rare, and interestingly, they're usually dogs that have mainly very localized cutaneous signs, and where they can find the organism, they treat it, they respond, but they remain seronegative. I don't know why they do that, but it does happen. But I think we shouldn't see that as it's an exception. Most sick dogs with Leishmania will have positive titers, and usually high titers.
Okay, cool. So we've diagnosed we've diagnosed a patient with Leishmania. How would you, I suppose if you've got a patient that's only got cutaneous signs, what kind of, you've done your serology or you've done your skin scrapes and you've demonstrated the organism. Before you decide to treat, are there other things that you would do that's going to influence your treatment decisions?
Yes, so they should always have a full hematology and biochemistry panel. So you want to look at things, particularly things like creatinine, because the prognosis changes a lot depending on whether they've got renal disease or not. You want to look at their proteins, because many of them will be hypoalbuminemic. You want to look at their urine, because some of them will be proteinuric. And if they are proteinuric, then you want to treat them, apart from treating the Leishmania, you might want to start them for standard treatment of a protein-losing nephropathy. Full bloods and urinalysis is an absolute baseline.
Yeah.
And obviously you might want to do other things, because remember that they might have Leishmania and they might have something else. So you might, particularly if the the signs don't completely fit, then you might want to make sure that you're not dealing with a dog with Leishmania and another disease. And particularly if you're using small number of tests. So for example, you're just doing serology in a dog with fever, for example, I would just say, well, be careful, because fever is not a common presenting sign of Leishmania. And also remember that co-infections are extremely common. So a dog that's been exposed to sandflies may also have been exposed to a tick carrying Babesia, or a tick carrying Ehrlichia, or a mosquito carrying Drosophila. So co-infections are very common in Europe. So just test for, if a dog is positive for Leishmania, make sure that you've tested for Ehrlichia, make sure that you've tested for Babesia, make sure that you've tested for the Drosophila. I might be forgetting others, but just bear in mind that co-infections are common.
Absolutely. So I mean, the take-home message is, you get a positive result. We look at the problems that the patient's got, make sure that the problems can be explained by Leishmania. If they're not, then you start looking for other diseases. If they can be explained by Leishmania, you still need to do biochemical, hematological and urine analysis, because you need to make sure that there's different degrees of disease that are going to influence your treatment choices, which we're going to talk about now.
Yes, and there is a staging system. That if I would encourage everybody to look online at LeishVet guidelines. They're very useful, and there is a staging system that gives you some guidance on when to treat, how to monitor, and so on. So there are 4 clinical stages: stage 1, stage 2, stage 3, and stage 4. The last 2 stages are dogs that have concurrent renal disease, and the prognosis is much worse for those dogs. But have a look at the clinical staging system. I think it makes more sense to read through it rather than me just
regurgitate.
Yeah.
But what about the drug therapy that you use? There's allopurinol and there's a few other bits and bobs.
Yeah, so they're usually, particularly in endemic areas, they use a combination of 2 drugs in the treatment of Leishmania. So historically, they've used allopurinol and meglumine antimoniate, which is an injection. The problem with meglumine antimoniate is that it's nephrotoxic. So treatment becomes more difficult for those dogs with severe renal disease. It's an injection, and it's being given either once daily or twice daily, and the injection is painful. So it's difficult. The treatment is difficult in that sense, because you're asking owners to give their dogs an injection that's painful. So those are the main 2 problems with that drug. There is a drug that's been used more recently, which is miltefosine, which is oral. It's not nephrotoxic. It has to be used in combination with allopurinol. And it can cause some vomiting and diarrhea, but it is a nephrotoxic and it's oral, so it's much easier. The problem with miltefosine is that it's extremely expensive. So you could end up spending, in a 10-kilo dog, £600 for a 1-month course of treatment.
I know. I looked into that drug for I think it was a German Shepherd, and it was just eye-watering. But I have to admit, because I've been off for a few months, I can't remember the availability of those drugs. I mean, this is obviously changes, but some of those drugs we had to try and import.
I mean, you need an import license in any case. So you need to apply for an import license and then get it. It used to be that we could get it from Verbag. There are different. Once you get the approval on your import license, they give you a list of places that you can get it from. I haven't recently tried to get it, so I don't know what the availability is at this moment in time. I would need to check that.
Yeah, but it's always something to consider, I guess, with the availability, and things might change with the current at the moment we're in the COVID situation, but we don't know how drug importations are going to change with Brexit and things like that. So, so we treat our patient with Leishmania, and now we've got to monitor it. Kind of assess and refine treatment. What approach should we take in that situation?
So monitoring is extremely important, and quite often people they've spent so much money on the treatment that they want to save on monitoring. And I'd say that monitoring is one of the main keys to success of treatment. because the treatment is not curative. We know that. So that dogs that are infected will remain persistently infected. And what you're trying to do with monitoring is prevent the development of clinical signs, progression of the disease. So, for example, end-stage renal disease.
Mm.
So you treat, so normally they will get the initial 1 month of miltefosine or meglumine antimoniate, and then you continue with allopurinol. And at the beginning, you monitor bloods, so hematology, biochemistry, and urinalysis every 3 months. And what you're trying to do is just make sure that they're not developing renal disease and that the proteinuria is reducing.
Okay.
And also that other parameters are normalizing. So albumin is normalizing, globulin is normalizing, and that would give you an indication that you're getting rid of the parasite, or at least that the load is reducing.
Okay.
If you're not seeing that, if you're seeing that the globulins keep going up, or the animal, then you need to start thinking, actually, my initial treatment isn't working. Do I need to use a different drug? So if you use miltefosine, shall I change over to meglumine antimoniate? You don't want to make the decision too quick because it takes a while. So things are not going to normalize in the first month, but you should see an improvement in the clinical signs and an improvement in the biochemical parameters.
Okay.
Once you see that everything has normalized, so the dog doesn't have the clinical signs have gone, and that the biochemical parameters have normalized, that would be the time when you start considering stopping allopurinol.
Okay.
And then when you stop allopurinol, so you stop all treatment, you continue to monitor. Initially every 3 months. If they're stable, you can do it every 6 months. And then every 6 months or so, you want to do serology. And that's really important because, and you want to do quantitative serology. And this is something that I didn't mention earlier, actually, which I should have done. But quantitative serology is much better than qualitative serology. You want a titer because the titer gives you an information on the clinical course of that disease. So ideally, before stopping treatment, you want to have a negative or very low titer.
Yeah.
If you continue to have a high titer, that means that you've got active infection and you should continue treating.
Yeah.
And then when you monitor, you want the titer to remain low or negative. When you start seeing the titer going up, infection is becoming active again. And that would be the time when you might choose to restart treatment.
Yeah. So if anything, you might start to get an elevation in the titer before the patient becomes clinically affected.
Exactly. And you want to catch them early. So treatment will be a lot easier if you're dealing with mild
stage
disease.
1 or 2. Yeah.
Exactly. Yeah.
Okay, cool. So I guess moving on to the final area with any infectious disease, we know about the sandfly and the transmission cycle. What advice can we give to owners about prevention?
Yeah, so the main mode of prevention is to avoid the sandfly in the first place. So preferably do not take your dog to endemic areas. So that would be my first advice.
Yeah. So minimize any risk by not just taking the risk.
Yes, exactly. Yeah. If that's not an option for the client, then there are good products, effective products that repel sandflies. Obviously, none of these products are 100% effective, but there are good products out there. There are spot-on treatments. So permethrin products, and there are collars as well that you can put on the dog that repel sandflies. It's really important that they follow the instructions on how to apply them, and also that they follow the instructions on frequency of administration. So some of the spot-on treatments, you need to reapply every 2 weeks for them to continue to have repellent activity. So always clients have to follow their vet's advice and follow the instructions in the package about how to use the product. That's the best way of avoiding the infection, not being bitten by the sandfly in the first place.
And then the website that you mentioned, is that where they've got details of all those kind of products as well?
They do.
The prevention.
They do.
So we've got a nice comprehensive list.
Yes.
And then what about I remember traditionally people used to talk about times of day that the sandfly would come out. Is that, I presume that's still part of the advice?
It is. So the sandfly is usually active at night. So when it starts getting dark, that's when the sandfly becomes active. So keeping your dog indoors at night is important. Obviously, the longer they spend outside, the more likely they are to be bitten by the sandfly. So just keeping dogs indoors in endemic areas, particularly at dusk. is important. And also the time of the year. So the sandflies are usually active between April and November.
Okay.
So they're not usually active during winter, but you know, the same with ticks, right? There are some of them that may be active, but it's rare.
And plus, at the moment, the weather's getting, you know, you'll get a nice sunny day in January sometimes. You know, so the weather's a little bit more unpredictable at the moment.
Yes.
So,
but it would be unusual for them to be active during the winter time. So.
Yeah. Brilliant. Cool. Well, we hope everybody who's listening or watching has found that useful. Like I say, we're going to do a little series of infectious disease focused out of hours podcasts. Myself and Patricia will hopefully record one on leptospirosis in the next day or two. So keep an eye out for that. And of course, if you want any details or want to be alerted of any of our CPD, be it webinars, be it the availability of podcasts, or having pre-recorded podcasts passed on to you so that you can listen to them at another time. If you contact our marketing department, the email address is just on the post. And also, finally, just to say, you know, this time, I hope everybody stays safe.
Thank you for listening.